It's a great pleasure to be here. So, Professor Amara, Professor Hanning, Nuha. So it's really good to be here. So, I'm going to speak a little bit about Lp(a) and cardiovascular risk. So, this is my disclosure. And so basically, this is Lpa, right? This is a highly heterogeneous lipoprotein, right? That everybody has in the blood, and actually Lp(a) was discovered in 1963, so the same year that I was born. So it's 56 years. So we know of Lp(a), and Lp(a) is an LDL-like lipoprotein, right? So the same conformation as LDL. However, it has an additional apolipoprotein that's called apolipoprotein little a. And this lipoprotein little a is very heterogeneous. And why? Because it's very heterogeneous, it complicates a lot the investigation of Lp(a). Just for an example, we have 40 different subtypes of Lp(a) in the blood, and each one of us might have a different one. And so this makes this lipoprotein actually very mysterious, you know. So I remember 1989, Professor Uterman published this seminal paper that was called "The Mysteries of Lpa," and at that time there was a lot of lack of knowledge about the metabolism, the function, the evolution, and the role of Lp(a). And actually, there were some hints at that time that Lp(a) could predispose to cardiovascular disease because apolipoprotein actually has a homology with plasminogen. And actually, Lpa could be the link between a lipid transport system, because it's an LDL-like particle, and the thrombosis system, because it might inhibit plasminogen. So that led to a lot of investigation about Lp(a). And actually, I was one of the members of the NIH-LBI working group on Lpa almost 30 years later. And actually, there's still a lot to know about Lp(a), but at the moment, we have strong evidence that this lipoprotein predisposes not only to atherosclerotic cardiovascular disease, but also to aortic stenosis. So there's been a huge advance to understand how Lp(a) levels are regulated in the blood, and its association with a greater risk of cardiovascular complications. However, we still don't know yet whether if we reduce Lpa, because it's too complicated to reduce Lpa, we will prevent events. And the good news now is that actually we have a medication that was developed specifically for Lp(a) that's going to be tested in a clinical trial to really prove the causality, because so far what we have is association, right? We know that it's associated, but we don't know whether it's causal. So the question is that comes is, okay, how many of us have high Lp(a)? Because actually, if you go to the observational studies, if you go to the Mendelian randomization studies, as I'm going to show you, we find a strong association between higher Lp(a) and a greater risk of cardiovascular disease, myocardial infarction, stroke, and aortic valve stenosis. But the question is, okay, how many of us have high Lp(a)? The problem with Lpa is that, as I said before, it's an extremely heterogeneous lipoprotein. It's differently from LDL, right? Because Lpa is genetically regulated, and if we come back a little bit to its molecule, actually, if we take a look, there's this. This is apolipoprotein, and apolipoprotein actually has a similarity with plasminogen. And if you take a look at the conformation of the protein in apolipoprotein, actually we have this, what they call kringles, that look like those Danish biscuits, like Pringles and things like that. So, and actually these kringles are very polymorphic, especially kringle 4 type 2. So we have 10 different forms of kringle 4, and type 2 actually is the one who determines the concentration of Lp(a). And we have 40 different forms of this kringle 4 type 2A. So that's why the lipoprotein is so heterogeneous. And depending on the ethnicity of individual, we might have different distributions of Lp(a) in the blood. So let's say for Caucasians, for Hispanics, for Oriental people, actually we have let's say a skewed distribution of Lp(a) towards lower values. So we have around 20% of these individuals with high Lp(a). But if you go, for instance, for black African individuals, actually we have a more bell-shaped distribution, more homogeneous distribution, and towards higher values. And these depend on the type of subtypes of ApoA particles that someone might have. So if we have bigger particles, we have lower Lp(a) levels, because these particles, they get trapped into the liver because Lp(a) is synthesized by the liver. But if we have smaller isoforms of ApoA, we'll have higher values. And these values are predominantly determined by genes. So depending on the kind of genes that you might have higher or lower Lp(a). So we estimate that we should have around 1.4 billion people with high Lp(a). So probably 1 in 5, around 20% of the population will have Lp(a). And as I said before, depending on the ethnicity, you might have higher or lower prevalence of elevated Lp(a). And as I said, the question is, okay, so why would we have this tremendous heterogeneity in Lp(a)? Differently from Lpa, where diet can influence, from LDL, where diet can influence LDL concentrations. Actually, diet, exercise, weight, actually they don't have much association with Lp(a) levels. And basically, genetics actually determines higher or lower Lp(a) levels. So that's why the Mendelian randomization studies that tested the genes that raise Lp(a) and were so instrumental in showing the association between higher Lpa and a greater risk of cardiovascular events. Lpa can also might be influenced by inflammation, but a little bit. So sometimes when you have an infection, or if you have a rheumatic disease that is uncontrolled, like lupus or rheumatoid arthritis, actually Lpa levels might be higher when the disease is active. When the disease is no longer active, Lpa levels will go down. But interesting, after the age of 4 or 5 years old, most individuals will not have changes in Lp(a). So that you can measure Lp(a) in someone who's okay, with a good health status, and you have the Lp(a) levels for the rest, representing the levels for the rest of the lives of these individuals. And as I said, actually, on the last 30 years, we do now have strong evidence that Lp(a) really causes cardiovascular disease. And the thing is, the problem is, as a practical clinician, okay, should we measure Lp(a)? And also in which person we should measure Lp(a)? There's a lot of debate about this. And the problem with Lp(a) is that because it's a complex particle. It's not like LDL, that is more simple, right? And Lp(a) is a complex particle. And as I said, we have 40 different subtypes of Lp(a) in the blood, and each one of us might have a different one, depending on the genes that we get from our parents. And that's the thing. And also because of that, there's a lot of problems with how to measure Lp(a). We don't have a good assay that is reliable in clinical practice to really have, let's say, a precise value of Lp(a) in the blood. Usually the size that we have, actually they measure the mass of Lp(a), not the number of particles. And actually we would have, for a more precise evaluation, we would have an assay that could measure the number of particles. And actually this mass depends on the Lp(a) isoforms, right? And interesting, 30 to 5% of Lp(a) mass is composed of cholesterol. And actually, Lp(a) cholesterol is accounted when we measure total cholesterol and when we calculate LDL cholesterol. And interesting, we suspect someone who has high Lpa when we give a statin to a patient, and LDL reduces less than expected, because actually statins don't reduce Lp(a). And that Lp(a) cholesterol is accounted as LDL cholesterol. So there's been a huge effort from clinical chemistry companies actually to come with good assays for Lp(a) in order for us to have a better measurement of this lipoprotein. So we have to consider all these clinical trials that measure Lp(a). Actually, they have these limitations regarding the determination of this lipoprotein. Okay, so why would Lp(a) be associated with a greater risk of cardiovascular events? First, because it's like an LDL particle, it's rich in cholesterol, right? Second, because Lp(a) is highly pro-inflammatory, because Lp(a) carries oxidized phospholipids, and the greater the amount of Lp(a) in the blood, the greater the pro-inflammatory process that it can induce. And also, since apolipoA has homology with plasminogen, actually it can inhibit fibrinolysis and can induce thrombosis. But interesting, as I'm going to show you, actually there is association with arterial thrombosis and not with venous thrombosis with Lp(a). So, okay, what is the evidence that we have? Actually, initially we had evidence from prospective observational studies, right? And actually there was a lot of controversy whether Lp(a) was associated or not with the greater risk because of the assays. And also because actually if we, let's say we have frozen samples of Lp(a), actually with time, these samples tend to degenerate and we lose the amount of Lp(a) tends to go down. Okay, so there's a lot of discussion, but probably this is the biggest and the best evidence from observational studies that showed an association of Lp(a) with a greater risk of cardiovascular disease. This is the Emerging Risk Factors Collaboration. This is a huge meta-analysis of prospective studies, and let's say that if we increase Lp(a) by 3.5-fold, we'll have a 13% higher risk of myocardial infarction in comparison with lower levels. And if we try to compare Lp(a) with LDL, we'd say that actually LDL is 4-fold stronger than Lp(a) as a marker of cardiovascular risk. So there was a lot of controversy about this one because of different assays, frozen samples. So, and also we might have the problem with the observational studies is that we can have the so-called unmeasured biases, right? Because there might be some other factors that even if we adjust, we can't take these factors away, and also reverse causation. So in order to prove that Lp(a) is associated with risk, we would need the genetic studies. And actually on the last decades, we have very, very elegant studies showing that the genes that raise Lp(a) are associated with a greater risk of cardiovascular events. So there's no chance of reverse causality here when you use the genetic studies. And actually, this is a summary of many studies and Borg Nordestgaard and Ann Langsted actually they were the authors of many of these prospective Mendelian randomization studies where we test the genes that raise or lower Lp(a). We test the values and we make an association not only of the values of Lp(a) with a greater or with a lower risk of cardiovascular disease, but also the association of the genes that cause these changes in Lp(a) with events. So that's what we call the Mendelian randomization studies. And they are very strong studies that really I can say prove causation, because to prove causation we have to reduce Lp(a) and reduce the risk of cardiovascular events, but there are very strong indicators of this that this association is real. And actually, if we check the genes that raise Lp(a), we will see a strong association with greater risk of myocardial infarction, a greater risk of ischemic stroke, and also with a greater risk of aortic valve calcification and aortic valve stenosis. So it's very clear, not only from these studies that were done in the Danish population, but also studies done with consortia of genetic consortia showing this independent association. Interesting, as I said, it might inhibit plasminogen, but they didn't find any association with venous thromboembolism. So no association with DVT, no association with pulmonary embolism. But we believe that Lp(a) actually increases arterial thrombosis, and when the plaque suffers a rupture or erosion, I think Lp(a) can contribute for arterial thrombosis and the consequent myocardial infarction or consequent ischemic stroke. And actually, one of the most interesting associations that we have found so far was the association of Lp(a) with familial hypercholesterolemia. Right? We know that FH in 95% of the situations occurs because of defect on the LDL receptor. So the LDL receptor cannot clear LDL adequately. And one might think, oh, since Lp(a) is an LDL-like particle, probably if the LDL receptor doesn't clear LDL adequately, it might not clear the Lp(a) particle. And actually, if we check Lp(a) values in FH individuals, we will find a gene dose effect with the association of Lp(a) levels with the defects in FH. Actually, homozygous FH patients usually have higher Lp(a) than heterozygous FH patients, and heterozygous FH patients have higher Lp(a) levels than normal lipidemic individuals. However, it's very controversial whether the LDL receptor clears Lp(a) because actually ApoLA does not allow ApoB to bind the LDL receptor. And if we give statins that we know that increase the expression of the LDL receptor, they don't reduce Lp(a) at all. However, on the other hand, if we give a PCSK9 inhibitor that we know that increase the expression of the LDL receptor, actually Lp(a) levels will go down by around 25%. So this is another mystery of this lipoprotein. Does the LDL receptor have anything to do with clearance of Lp(a)? So this is something still intriguing. On the other hand, actually, there's this study that I had the pleasure of writing the editorial on the Lancet that suggests that actually high Lpa might be also a cause of FH. Because let's say that Lp(a) cholesterol is accounted as LDL cholesterol or total cholesterol, and if you use the clinical criteria for diagnosing FH, and let's say 1 in every 5 Caucasian individuals who have high Lp(a), actually this cholesterol, Lp(a) cholesterol, will be considered as LDL cholesterol, and if you use clinical criteria like Dutch Clinics Network or the Simon-Bloom criteria, actually probably 25% of people that we call FH only on clinical grounds actually might not be FH, but might be high Lp(a) people. So this is something very interesting. Independently whether the phenotype might be or not might be caused by Lp(a), we have strong evidence, not only from studies in Denmark, but also from studies in Spain, that if you have FH and if you have high Lp(a), you have a greater risk of cardiovascular disease. So probably the risk is 50% higher if you have high Lp(a) in your FH. So this is something that is very important, and we can use Lp(a) as a way of stratifying the risk of cardiovascular events in FH in individuals. And interesting, actually, there's an elegant study that was published by the group of Professor Pedro Mata in Spain that they show that many FH individuals actually they also inherit genes for high Lp(a). So if you do the cascade screening, not only for high LDL in the families of people with FH, you will also find a greater number of individuals with high Lp(a). So you should measure not only LDL cholesterol, but also Lp(a), not only in the index case, but also in the relatives of people with FH, and you have a greater chance of finding higher Lp(a) in these families. And this is the discussion nowadays is, okay, whom should I measure Lp(a), right? We just the last speaker just quoted the new guidelines, right, that were published by the European Society of Cardiology, right? This one was on diabetes, but at the same time they published one with the European Atherosclerosis Society on cholesterol management, right? And actually in these new European guidelines, they are recommending general evaluation of Lp(a). So everybody should have at least once in a lifetime one measurement of Lp(a), considering that 1 in every 5 people will have high Lp(a). This is a little bit controversial. If you go to the American guidelines that were published last year, actually they don't recommend to measure Lp(a) in everyone. If you go to the NLA guidelines, National Lipid Association, that also published, I think this year, they also don't tell us to screen Lp(a) in everyone. But for whom should we measure Lp(a) at least? Families with early history of cardiovascular disease, okay, because since there's this autosomal transmission, dominant transmission of Lp(a) genes, okay, I might transmit my genes to my kids, right? Second, FH patients, because there's this association of high Lp(a) with FH, right? Individuals with recurrent atherosclerosis events. So, okay, you treat the patient with statins, aspirin, and so on. The patient keeps having events, so might have Lp(a), high Lp(a). As I said, since Lp(a) cholesterol is accounted as total or LDL cholesterol, you give a statin, LDL cholesterol goes lower than expected, might be high Lp(a) together with high LDL. So individuals whose LDL drops little with statins, and possibly individuals where we calculate the risk, primary prevention individuals, and these individuals are considered as intermediate risk. So if they have high Lp(a), they might have a greater risk of events. And so we might reclassify these individuals to a greater level of risk. And as the Europeans recently recommended to measure in everyone. Okay. The problem is that we might say, okay, if I measure Lp(a) and Lp(a) is very high, what should I do with these patients? Because the problem is the treatment, right? So far, we don't have let's say, an adequate treatment for high Lp(a). And sometimes that causes a lot of trouble with the patient, because some patients might get very stressed, anxious about high Lp(a) levels. Okay, so what to do with high Lp(a)? So that's the question. Because as I said, do we have treatments for high Lp(a)?
Yes.
Should we treat the other risk factors if we find high Lp(a)? So that's the intriguing question, right? And actually, basically what we recommend is if we find someone with high Lp(a), we have to treat the other risk factors very aggressively, okay? Control blood pressure, control glucose, reduce LDL very intensively. And there was this discussion about statins and Lp(a), because we have evidence that statins don't reduce Lp(a), but there were some studies actually suggesting otherwise, that actually statins could raise Lp(a) levels. Some paradoxical effects of statins, right? Actually, there was this very elegant patient-level meta-analysis that was published on The Lancet last year, and actually they didn't find any association of statins with Lp(a) levels. Okay, statins won't reduce Lp(a) levels, but on the other hand, they won't raise Lp(a). So this is great. However, they found that actually, even if we treat LDL cholesterol very aggressively, Lp(a) will still be an independent marker of occurrence of events. So even if we treat LDL, okay, we will reduce the risk because we're reducing LDL, but the risk still will be high if Lp(a) is high. So it clearly shows an independent association of Lp(a) with a greater risk of events, even if we treat the other risk factors. So, okay, what should we do to reduce Lp(a)? We know that niacin can reduce Lp(a) by around 25%. We also know that PCSK9 inhibitors can reduce Lp(a) by around 25%. But we have no proof at all that if we reduce LDL by these amounts, we will reduce cardiovascular events. And actually, even if we reduce LDL very intensively, as we saw in the Fourier study, remember, high-risk secondary prevention individuals already taking statins, some 50% were randomized to evolocumab, reduced LDL from 90 to 30 milligrams per deciliter, very low LDLs. Still, if Lp(a) was higher, there was a 12% greater relative risk of events, even if we reduce very intensive LDL. So, actually, high Lp(a) may be an indicator for more extreme LDL cholesterol reduction, because it might identify a greater risk individual. So, okay, so do we have evidence that actually if you reduce Lp(a), we will reduce cardiovascular events, we will reduce cardiovascular mortality? So that's still a mystery that needs to be unsolved, because actually we didn't have a study actually that was designed to really prove that if we reduce Lp(a), we would reduce the risk of events. And the question that comes is, how much Lp(a) should I reduce to prevent events? So that's the thing. Actually, to really have a clinical trial that will be successful in really proving that if we reduce Lp(a), we will prevent events, we need first high-risk population with high Lp(a) levels. Okay, so we have from the Mendina randomization study some controversial results. Okay, so how much Lp(a) should I reduce to prevent events? There's one study that suggests that I should reduce 100 milligrams per deciliter of Lp(a) to have the same impact as reducing 1 millimole or 39 milligrams per deciliter of LDL cholesterol from cardiovascular events. So let's say if I reduce 1 millimole per liter of LDL, I will reduce the relative risk by 22%. So to reduce the risk by 22%, by reducing Lp(a), I'd have to reduce Lp(a) by 100 milligrams per deciliter. Okay, we say that high Lp(a) is around over 30 in some populations, over 50 in some populations. Okay, so we need people with very high Lpa to really prove that reducing Lpa will prevent events. On the other hand, there is another study, Mendelian randomization study also, genetic studies, suggesting that actually I might need to reduce Lpa not by 100, but by 66 milligrams per deciliter to prevent events with the same efficacy as 1 millimole per deciliter reduction of LDL as the statins do. So there's this discussion. Okay, we don't know yet what would be the adequate amount to reduce to prevent events. Okay, how to do that? How to really reduce Lp(a)? The evidence that we have actually, if we try to deal with LDL removal, Lp(a) removal, we might not be so effective. But probably what we have to do is to reduce production. So we have this hint, right? This is an antisense oligonucleotide that reduces the production of ApoB. You know that Lp(a) has ApoB and apolipoA. So we have two apolipoproteins in the LDL particle. If we reduce ApoB production, actually we might reduce Lp(a) by 25%. Okay, so but this might not be enough, because 25% might not be enough to really reduce an intensive reduction in Lp(a). And now actually we have a very strong medication, okay, that reduces the production of apolipoA, that might reduce Lp(a) up to 80%. So it's a lot more stronger than all the other drugs that can reduce Lp(a) levels. And actually this drug was chosen for the clinical trial that will really prove if reducing Lp(a) will prevent or not cardiovascular events. This is an antisense oligonucleotide, okay? It's a new generation ASO, so the tolerability of this drug is a lot better than the former ones, with not a little, let's say, injection site reactions, flu-like symptoms, with a little chance of inducing thrombocytopenia, because that's what we saw with the other drugs like mipomycin or volanesorsen for ApoC3. Okay, so this drug is a lot safer than the other ones. And the good news for the patients is that you have to take one injection each month only. So that's great. So you reduce LDA by 80% with just one shot per month. So this is good news for the patients. And actually, this is the clinical trial that's called LPA Horizon. Okay, so the study will get secondary prevention patients already had a myocardial infarction or had an atrial stroke with high Lp(a). Okay, we have to have high Lp(a) to participate in this study. And so they will enroll patients with Lp(a) over 70 milligrams per deciliter. Okay, they will take this drug once a month or a shot of placebo once a month. And this study is powered to show that if we reduce Lp(a) by up to 80%, we will prevent events by around 20%. So hopefully this trial will be positive, and hopefully we will come with some, let's say, hope for our patients in the future. To conclude, after 30 years, Lp(a) is a little less mysterious than it was in the past. Now we have strong studies showing that this is an independent marker of cardiovascular disease, not only coronary artery disease, stroke, but also aortic valve calcification and stenosis, right? The lipoprotein is genetically determined. Probably 1 in every 5 people will have high Lp(a), right? There's this discussion, whom should we measure? Should we measure Lp(a) in everyone or in some specific groups, right? What to do with high Lp(a)? Okay, control the other risk factors. At the moment is what we can do, right? And hopefully this new treatment will reduce not only Lp(a) but also will prevent cardiovascular events. Thank you very much. Shukran.